Let's go through Uwe Reinhardt's book, Priced Out. But first, let's get to know the Organization for Economic Cooperation and Development. The OECD is a group of 38 countries with a similar manifesto. Capitalism. Reinhardt uses their data to compare U.S. healthcare to that in similar countries. While Priced Out is a decade old, as a comparison between countries, it paints the unflattering picture of American healthcare that continues to this day. This first graph tells all. The U.S. spends more of its resources on healthcare than any other country. Healthcare spending per person in the U.S. is also the highest of all OECD countries. Current OECD data for U.S. healthcare spending is about $15,000 per person. The U.S. has long been leading the pack with healthcare spending, but obviously this means we get better care, right? Our life expectancy is 78 compared to the OECD average 81. Avoidable deaths for those under 75 and suicide rates are higher. We have a lower percentage of poor self-reported health, less daily smokers, and less air pollution. Obesity rates are higher, but this could reflect the genetic makeup of the US population compared to other countries. See my series on the flaws of measuring obesity with BMI. Our vaccination rates are at par, and our 30-day mortality after stroke and heart attack is lower, but our number of avoidable hospital admissions is one of the highest. Average, maybe, but certainly not best. Add to this survey data showing US adults are more likely to forego medical care than adults in other countries. We skip more recommended tests, treatments, and follow-ups, as well as more prescription fills and refills. In a manner consistent with the American bootstrapped spirit, we wait until things get so bad that we end up in the hospital. Back to square one. What about our aging population? By 2030, about 20% of the US population will be over age 65. On the whole, though, we're young compared to other countries. Japan is much older and yet still spends less on healthcare. If anything, this graph goes to show that healthcare spending is not affected by population age. Back to square one again. Let's look at the International Federation of Health Plans 2024 International Healthcare Cost Comparison Report. For 12 common inpatient procedures across 9 countries in 2022, US costs were more than double the average of the other 8. And we're talking a difference of tens of thousands of dollars here. The report notes US costs are driven by its fee-for-service payment model, incentivizing quantity over quality. This is a well-known issue. Reinhardt made the same argument 10 years earlier. For outpatient procedures, the US is somewhat closer in prices, but they're still above average. But it's not just high prices that get us. It's also that price depends on who's paying. There's a difference between what hospitals charge, the price negotiated with insurance, and Medicare reimbursement. Reinhardt describes it best here. Charge refers to the list prices each hospital has in its charge master. Each hospital composes its own charge master using methods that remain a mystery to outsiders. The charge masters of different hospitals don't even have a common structure and nomenclature. Only a few state governments have the temerity to require hospitals to post their charge masters on their websites. However, uninsured patients with some means typically are charged these high list prices. Hospitals then use any means, including debt collectors and the courts, to collect on bills at these high charges. Medical bills on charges can easily bankrupt a family. Usually, private health insurers negotiate the price they will pay hospitals in the form of discounts off the hospital's charge master. Finally, Medicare prices are those paid by Medicare. In principle, they're set to cover the average cost of hospitals, although for some hospitals there's a shortfall of Medicare prices from costs, while for other hospitals, Medicare's prices may yield a positive profit margin. A fascinating feature of US prices for healthcare is not only that they vary so much across this huge country, but also that they vary just as much within localities. The highest price for a knee replacement in Denver was 3 times the lowest, resulting in a difference of tens of thousands of dollars for one procedure in the same country, in the same state, in the same city. As Reinhardt says, total chaos reigns. Basically, healthcare providers and drug manufacturers charge the highest price they can get away with, knowing that insurance will pay part of it, some of the insured will pay out of pocket, Medicare reimbursement may or may not cover it, and they'll lose money on people who will go bankrupt trying to pay for it. and who benefits from this obfuscation of profit. Healthcare administrators are a workforce that grew an order of magnitude greater than doctors over the 40 years from 1970 to 2010. But healthcare administrators aren't greedy value vacuums. They're a necessary part of an overly complex system. While most countries group their citizens into the same pool of insurance, the US, in deference to consumer choice, divides its citizens by age and income. If you're below a certain income, you get Medicaid, which can combine with Medicare if you're over a certain age. If you work, you and your family are covered by one of over 1,000 different health insurance companies. If you're what this figure calls the near poor, which means not meeting the federal poverty level for Medicaid, but not lucky enough to have a job with health insurance benefits and or to make enough money to purchase your own healthcare insurance, then you might be part of the millions of uninsured Americans, or eligible with an income of up to 100% the federal poverty level as a qualified Medicare beneficiary, or QUIMBY, to have your Medicare experiences covered, or eligible with an income of 100% to 120% the federal poverty level as a SLIMB, or specified low-income Medicare beneficiary, which only pays for the monthly Medicare Part B premium. Medicare Part B covers like the non-hospital things that Medicare A covers, but not drugs, because that's Medicare Part D, except Medicare Part B does cover some drugs. It does also cover vaccinations, but it doesn't cover all vaccinations. Oh, and there's also QI1 and 2, which have something to do with SLIMBs between 120% and 130% the federal poverty level, but I don't know how that works. And also I don't know what QDWI means, and half this stuff I had to look up because Reinhardt doesn't even tell you what they are or even what the acronyms stand for. And the other half I have to know just because it's part of my job. So yeah, you can see why we might need so many healthcare administrators. Reinhardt references a 2013 Institute of Medicine report saying that these excess administrative costs make up about a quarter of excess costs. Despite how much we like to rail on bad actors, fraud here only accounted for about 10% of costs, and while $75 billion on the national scale is not insignificant, we clearly have a much bigger issue going on at a systems level. Our financing structure incentivizes unnecessary services, higher administrative costs, higher healthcare provider and drug manufacturer prices, and fragmented, inefficiently delivered care, all while disincentivizing public health prevention measures. Altogether, these costs were about 30% of healthcare spending in 2009. Speaking of drug manufacturers, we haven't had the chance to call them out yet. For those of you with private insurance, let's play Where Does $100 Paid Towards Drug Costs Go? It's a fun game I came up with a minute ago. About $16 is going to go towards marketing and admin for your health insurance plan. Pharmacy benefit managers, the middleman between your insurance company and drug manufacturers, take $5 off of that to ostensibly negotiate lower drug prices, but they suck at it, and there's like some sort of weird secret rebate system going on that no one knows about. Another $15 is going to go to be profit for drug manufacturers. Only $17 of those $100 are going to be spent towards the production costs of the drug itself. How do other countries deal with all this obfuscation? They don't. Instead of thousands of different insurance pools, most OECD countries pool large groups, if not their entire population together. This simplifies payment systems and lowers costs, but also brings more bargaining power to the table when negotiating with healthcare providers and drug manufacturers. The IFHP's suggestion to the US is to 1. Centralize price negotiations to a single payer system, or at least something less than a 1,000 payer system, and 2. To shift towards outcome-based payments. It didn't go. Outcome-based payments, there we go. To shift towards outcome-based payments rather than fee-for-service payments. And so I think we're ready. We have textualized the US healthcare system and its flaws with the rest of the world, and we can now consider what could universal healthcare look like for the US?
Is such a thing even possible?
Uwe Reinhardt's answer to the latter question was not very optimistic. I'll break down his argument as well as universal healthcare right here in 2 weeks. Oh, and if you didn't get enough numbers over the past 10 minutes, here's a breakdown of how out-of-network prices vary drastically from Medicare prices.
Okay.